Hey everybody, it's Karen Anderson here with Aortic Hope for a very special live event. But before we get started, do me a favor, click that like button, click that subscribe button, the bell, because if you don't, you're going to miss when we have these types of live events. And this has been a very busy February, and they only get busier from here. I mean, it's Heart Health Month, it's Marfan Awareness Month, it's Heart Valve Disease Awareness Month, Black History Month. I mean, we've been covering so much information, and these live events just pop up here and there. So we are going to move right into our guest today, which is like one of our very popular shows, is always having you on, Dr. Ben Youdelman, cardiothoracic surgeon from my Maimonides Medical Center in Brooklyn, New York. How are you today?
I'm good, Karen. Thank you so much for having me during this Heart Month. It's certainly a wonderful time to spend time together with you, as always.
Always. Yeah. And you know what? I'm really excited because we actually have a topic planned for today. Usually we just kind of tend to wing it, but based upon your poster, glaring Think Aorta in the back, one of the things we always talk about is how aortic dissections are rare. Unless, of course, if it's happening to many people in your family, but aortic disease is much more common than we think. So let's jump right into explaining to people, what does it mean when they're told they have aortic disease? What's that mean?
Well, I think we should take a step back, Karen.
Step back.
Yeah, and actually, unfortunately, I have to go, but this has been a lot of fun. No, just kidding, everybody. So, going to the prop, the aorta itself, this is a fake heart, but the aorta itself comes out of the left ventricle, and it's a sort of a candy cane shape, and it goes up and over, gives blood vessels to the heart, and then it gives blood vessels to the brain and your arms. Then it goes down the back, and it does a bunch of other cool things. The aorta is the largest blood vessel in the body, and the most important thing to know about it is that it is the source of all of the blood flow to every single part of your body. It's not a part of it, it's the main trunk. So problems with the main trunk can cause all kinds of problems. But the issue with regards to aneurysmal disease is just when the main trunk itself is bigger than your thumb. Now, as I put it close to the camera, it gets bigger as the size of my head, but as I pull it back, it gets to be the normal size of a thumb. Some people say that it's about an inch and a half wide, but at the widest portion of your thumb is right about the size of the normal size aorta. And all of my students never can believe this until they actually see it and they realize, oh, that's actually true. Now, it can be a little bit bigger, but when it gets too big, and that number is 4 centimeters. Now, how big is 4 centimeters? So here's my thumb, and here's a ruler, and my thumb is about almost 3 centimeters. So there you go. So that's the difference, right? So once you get to that size in diameter, you definitely have an aneurysm. Now, once you get to this size, and you can see that's roughly twice the size, very hard for me to put up 2 thumbs on one hand, but I'll do my very best. Nope, can't do it. But that's how you get to the size when you need surgery. And obviously, if you get bigger than that, that's when there's definitely concerns. And those concerns are that there'd be either a tear or a rupture. And we don't like to talk about those things, but that's why we operate on them early.
Okay. So aortic disease then encompasses what beyond just aneurysms? Do we add in heart aortic valve issues? Is that part of it?
It is not. And the reason that it's important to be clear on what you're talking about is that it's so complicated that we have to make sure that we keep things in their right space. Aortic disease does not have anything to do with the aortic valve or coronary artery disease where you need bypass surgery or stents. The aortic disease itself is related to 3 conditions. One is that it gets big. That's called an aneurysm. Number 2, there can be a tear in the wall that we'll talk about, and that's called a dissection. And then number 3 is a rupture. Everybody knows what that is. Taking a step back to dissection, the easiest way to think about it is there's the outside, the inside, and the middle. If you have a tear in the wall, it goes through the inner layer travels through the middle, and then comes back into the aorta, into the what we call the true lumen, that is a dissection. Of course, if it ruptures out, it's a rupture. And it's very complex when that occurs, for sure.
So if somebody has something wrong with their valve, and the only reason I keep bringing it back is I want to talk about the valve issues today as we're rapidly approaching Heart Valve Awareness Day in 2 days. If they have an issue with their valve, what conditions could lead to an aneurysm just after the valve?
Interesting question.
We know that people.
Questions are the sign of intelligence, and you've just stumped me with a really intelligent question that I don't know how to answer. So I'll be leaving right now.
Meaning there are people in the community a bicuspid valve, and then they realize after that's discovered, they find out they have an aneurysm.
Bicuspid. Don't confuse the person you're interviewing to have to get all stumpeted. All right, so listen, let's go back a step.
Let's keep taking me back.
Let's just take Karen out. Let's you and me talk, all right? Let's not talk about Karen. Let Karen just sit over there and laugh and be like her usual self. Now, you and me will talk, all right? We'll just the two of us. Here's the deal. The valve can be three cusped or three leaflet valves. And this is an example of a prosthetic valve that has three cusps going towards the camera. There's three posts. There's three cusps. This is obviously not the way you are made, but if you only have two cusps, it's called bicuspid, two cusps. You can actually have 1, 2, 3, or 4, all have been seen. The chances of you having 3 are about 96 to 98% of the population. Chances of you having 2 is about 2 to 3% of the population, and the chance of you having 1 or 4 is really small. But they do occur, and it all has to do with when you're born, when things get made, and whether they work or don't work. Now, what Karen is alluding to, subtly though she may be, is that a bicuspid valve is associated with 2 other conditions at a minimum. One of them is an ascending aortic aneurysm. Going back to the plastic situation here, the ascending aortic aneurysm is the area just above the heart itself. This would be where the valve is, this area right above the heart and heart valve. This would be an area below where the vessels come off to your right arm, but above where the vessels come off to your heart or the coronary arteries. And that is associated with a bicuspid valve. Just that portion. We're not going to go into all the theories behind it because we don't know, but it is very interesting that that is true. The second thing it's associated with is something called coarctation of the aorta. The coarctation is one of the most annoying words that exist. But in reality, coarctation, which no one should have to say out loud, but I have to say it all the time, coarctation of the aorta is when there is a narrowing of the aorta beyond the blood vessel from your left arm. So it's associated with a dilation in the ascending aorta and a narrowing in the descending, but not always, only sometimes. How annoying is that? It's very annoying. But when you have a situation where you have a bicuspid valve, we always have to look for that.
Okay. So before we move on, let's say you have to have your valve replaced. What would be the reasons why somebody might have to have a valve replaced? And what happens in that situation?
So valve replacement is just one of the few options that are available if there's a problem with your valve. Okay. Your valve can leak. Your valve can have a blockage in it, meaning that the cusps or the leaflets don't open very much. And one of those two conditions is associated with the aorta. 50-50, 50-50.
Regurgitation or leakiness.
Nice. If your aorta gets big, then the valve might not fit anymore. Just let's say you put in a door frame, like a 32-inch door in a door frame. 80 inches high, 32 inches wide, the door opens and closes. You go to sleep one night. Now the door frame goes to 36. All the neighborhood cats start coming into your house. It's not going to work. It's just like that. It's the same thing. If the door frame, which is the aorta, starts to expand because you have aneurysmal disease, then your valve can start to leak. When the valve leaks, it may need to be either fixed, which I can do, or replaced. Now, if you need to replace the valve, significant portion of valves are replaced with, going back to the prosthetic tri-leaflet valve. It has a nylon ring. It has some struts that have titanium in it. There's a little bit of plastic sewn together by really meticulously good seamstresses around the country and around the world from various companies. And these valves get put in, sewn in place. That is often done for either leaky valves or aortic valve insufficiency, or for valves that are blocked, called aortic stenosis. It is called aortic stenosis, even though it's really aortic valve stenosis. That's what it actually is. We just shortened it because, we're very busy. We can't say that extra word. Right. That would be a waste of our time. So aortic stenosis or aortic valve stenosis can be fixed with a number of things. Many of you have heard of these transcatheter valves, one of which looks like this. And the other one, unfortunately, I don't have a good example of it. Do I? No, I don't. But I don't want anybody to think I'm like preferential to one company, but the valve is put inside the aorta in the aortic root, right inside that and blown up. Now, that's for aortic valve stenosis. But very important, Karen, and you might want to write this down.
I have a pen and paper.
If you have aortic valve stenosis and also have an aortic aneurysm, putting in a transcatheter valve does not solve your problem. And there's a little bit of information, new information in the last couple of years, that if you do that, and then you have to go back in and do open heart surgery to fix the aneurysm, that may be a little more risky. So sometimes it's safer to do everything at once up front. But that's a super complicated digression that I'm not going to make. So just wipe that from this live broadcast on the 2-second delay, and then you don't have to worry about it. Thanks. Appreciate that. Thank you, Josh.
All right. Talk to me a little bit about the different types of valves. You just showed one, and so that would be considered, that one that you showed would be considered mechanical, or is that a sample of like a...
This is a tissue valve. So
that's
the tan part is not made of tissue, because me keeping that on my desk would be incredibly gross.
Yeah.
But this is made of rubber, right? And this is a tissue valve. This is given to a lot of people. But I'm going to show you, make it super complicated. In a valved conduit, I'm going to show you a mechanical valve. You can see it's made of metal. I have another one, but that's not sitting on this graft. But there's the idea. There's little leaflets that open and close. And that valve requires that you take a drug called warfarin, because if you don't, the metal causes your blood to clot, and that is bad. The third set of valves we have are the transcatheter valves, of which I just showed you this one. There's another one that is similar to this, except it's just this portion. 2 different companies, both extremely good, extremely effective, not for people who have aortic aneurysmal disease associated with their valve, unless they're too sick to operate on, do an open surgery, and that's a different conversation. But recently, if you put these in younger patients, it sometimes causes a little more trouble than we thought. as they get older. But this is way beyond the scope of this particular conversation.
How do people make a decision if they're allowed to do something elective? How do they first of all, do they get a choice between mechanical or tissue? And then how does one make that choice?
So you may have noticed that the society is broken up into two different sets of people, some of which can make people, and some of which can't. If you can make people, the warfarin is a very, very problematic drug. And if you're in the process of making a person and you're taking warfarin, it can cause birth defects. It can cause all kinds of problems with the pregnancies. It can result in termination of the pregnancy and all kinds of issues. And so you cannot take warfarin. So if you're in the baby making business, or you're thinking of jumping into the baby making business at some point in your life, then giving you a mechanical valve is a very, very bad idea. So we start with that. The next thing is in patients who are older, so this is all the way on the other extreme. Patients who are older, it doesn't make a whole lot of sense, to put in a drug that put in a valve that requires a drug that thins your blood, because as you get older, the chances of you needing some sort of surgery, the chances of you falling down, going boom, hitting your head, things like that can be increased, not always, but can be, and therefore you're at higher risk. But the other part, which I haven't mentioned yet, is that if you look at the tissue valves, they will wear out, quote unquote. We know that this is probably a series of immunologic reactions to the pig or cow parts that they're made from. And they wind up getting either torn or blocked up. And either one of those can be treated with a transcatheter valve inside those valves. And so as you get older, if your life expectancy is less than 15 years, we think that putting in a tissue valve is completely reasonable. So over 65, right? Our job is to get you to 80. Everything else is gravy. If you get a tissue valve at 50 or 40 or 30 because you want to make people, we may be able to put in a transcatheter valve and extend the life of that valve, or you may need a reoperation as well. So the decision is wholly up to the patient, and there's pluses and minuses. There are people that never want to take blood thinners because they may have known someone who had it and had a bad experience. There are people that never, ever want to have valve surgery twice. In fact, I know this may sound strange, but I've met a number of people, they don't even want to have valve surgery once.
Crazy, right? Go figure. All right. Well, that helps clear up a lot of things, because I know there's always a debate. There's the crew that are like, I want a one and done. There's the others like, I can't stand the potential of listening to TikTok the rest of my life. So it vacillates back and forth, and we just we let them battle it out online. But thank you for the explanation. All right. So we're talking a little bit about insufficiency, stenosis, valve replacement. We can do it endovascular. We might have to do it open heart. Let's get into some more conversations here about aortic disease and what aneurysmal disease is. And we often talk about talking to your family about your medical history. Let's get into some nuances here that really pertain to why we all need to think about the aorta.
So the issue of the aorta is quite complicated. But we break it down into some very, very simple things, which is what is associated with the things that can hurt you. Aortic aneurysmal disease can result in rupture, dissection, or nothing. And it is not my job to scare the crap out of somebody for 20 or 30 years and then have them never have a problem with their aorta. But I have to take into consideration their family history. Why? Because all of us have to deal with the reality of our family histories. And if you're adopted, or if you're an only child with deceased parents and you don't really know what happened, you get into a situation where you wish you knew. But if you're lucky enough to actually know your family's medical history, you can prepare and have a preemptive approach to a lot of the obvious things that may result in your injury or death. Now, if we're focusing on the aorta and you know that people in your family have had cerebral bleeds and they passed out, they went into the hospital, they were out of it for a number of days, they said that they had an aneurysm in their brain, but they don't need surgery, or maybe they did need surgery, or your grandmother had this or something like that, that is a connective tissue disorder variant that we see. Those are associated with aortic aneurysms. And the aortic aneurysms are from, again, the heart valve all the way down into the belly, where the aorta separates into the two great vessels that go into the legs. Aortic aneurysmal disease anywhere in the body is associated with aortic aneurysmal disease in other places in the body, probably in about a 30-35% association. But it also has a 10 to 15% association with cerebral aneurysm disease. Why am I going into this painful detail to annoy you and to talk about this during the call when we're all talking about nice things? Well, it's because the reality of it is that if you know this information, you can prepare. So how do you prepare? Somebody comes into my office, they had an echo because they turned 50 years old, and their ascending aorta is 4.5 centimeters up. Karen, is that big?
It's big. Bigger. It is. Yeah. It's bigger than your thumb.
Yes. There it is. So it's bigger than my thumb, but it's not big enough to do surgery, but it's something you should keep an eye on. They come into my office. I say, anybody in the family have any heart surgery? Yes. My father had heart surgery. I don't know what it was. Interesting.
Mm-hmm.
What about your mom? Yeah, my mom had a big emergency surgery and she was in the hospital for about a month or 6 weeks, and she did okay for a while, but she was really debilitated, but then she got better. How about your sister? Oh yeah, my sister had a really bad headache one day and they went and they said she had something in her brain and they put a clip or something in her brain and she's okay. Okay, this patient is telling me that the father had elective aneurysm surgery, the mother had an aortic dissection, the sister had an aneurysm in the brain. This is a wicked, super high-risk person who I may offer surgery right there in the office. I may pull out my knife right there in the office and just slice them open right there.
Right. Yeah.
I've only done that never, but
right.
it could happen. No, it's not going to happen. But the point is that when you have this kind of association, you are pushing you all the way over to, am I out of the frame? I'm out of the frame, sorry. Pushing you all the way over here versus on this side, we've got a bunch of people. So on this side, who's that? Somebody gets the same echo. They come into the office and they say, hi, how are you? I say, hello. Your aorta is 4.5 centimeters. They said, that's nice. How's your parents? Are your parents still alive? Yeah. Both of my parents are 98 and they're both still alive. How about your grandparents? Both grandparents are 120. They're still alive. Well, there's 4 grandparents. 4 grandparents still alive, 120. How about any siblings? Yeah, all 10 siblings. Everybody's alive. No medical problems. So what does that tell you? That tells you that they don't have any aneurysms? No. It tells you that they don't suffer from dissection or rupture disease. But that doesn't mean that they don't have an abnormal aorta, because we know a lot, but we don't know everything. And if someone has an abnormal aorta and I can operate on them safely, then I take that out of their risk of injury, rupture, dissection, or death. But if nobody in the family has this, then I don't jump up and down and get crazy about it. We can just follow the standard normal algorithm and tell them, I can't tell you anything except you should be on some medicine and you should take it easy and we should operate on you when you get past 5 centimeters. But you are in the lower risk of this group versus the wicked high risk of this group. And that's a different thing. Oh, shoot. Am I backwards on the camera so that I just did the lower with the higher? It's okay? Because I'm sorry. I feel bad. I apologize. I don't want to screw it up.
But that person in that second example, if they have children, you would still want to at least do a baseline to see if their children have
Great
any
question.
potential enlargement?
So when everybody's identified as having a problem, whether it be the emergency or the elective identification, we evaluate the kids at age 50 or 10 years younger than the point of identification. The 10 years is to allow for the buffer with the assumption that even in the worst scenario, and we all have met people and have heard of these patients that have dissections in their 30s. Youngest one I had was 28. 10 years prior to that, that's an 18-year-old person. That's pretty wild. You know, if a 28-year-old person has a child, it's pretty hard to emotionally contend with their child potentially having a problem at that young age. Not to mention that if you take women and now you've got to evaluate them on a regular basis and you want to do CAT scans, so you do an MRI, which is very valuable and very helpful, but MRIs are not quite as precise yet. Soon, but not yet. So we do an echo, and then echoes also not quite as precise. And so we run into a little bit of evaluation anxiety. And do I really want to strap an 18, 20, 25-year-old with 50 years of anxiety? Of course I don't, but I have no other way to protect them except to get them into a routine of surveillance. You know, it's all I got.
Yeah. Well, one of the things that we hear community members complain about the very most when it comes to being in this watchful waiting time period is it's 4.7. I just want it out. I just want it out. Of course, now when I read these statements, I don't know anything about their family history, and it's not my business. I just know emotionally they want it out, and I can appreciate that. But I think that it would be helpful if people had a better understanding of more information that goes into when you make that decision. Because I've heard one physician say, well, we do take into consideration the quality of life and the anxiety level from the patient. And, you know, if we need to take it out to give them back a life, you know, we'll consider that. And I thought, that's interesting. That's never been presented to me. I've learned grounding techniques. I go to therapy for the anxiety. So what is it? Because if a lot of us, most of us, not all, are testing with nothing when we go get genetically tested, because everybody runs out to get genetically tested, how do they make this decision? Nope, we're still going to go. We're going to go another 6 months to a year. Nope, it grew, but we're going to go on. And then there's my second part is, what is growth? People think 2 millimeters. Oh my God, I grew in 3 months. They don't understand growth and different tests and different machines. So let's take the first one, I guess, which is, how do you even decide when it's time? It can't just be a standard one size fits all. Haha. You know what I mean?
Well, Karen, first, I want to thank you for asking that many questions in that quick a period of time. I think that's a record. I believe that was 17 questions in exactly 64 seconds. So congratulations. You have won this. No. Okay, so let's take it back 17 steps.
Okay.
Anxiety in medical diseases is a very real and very dramatic phenomenon. No, not phenomenon, reality. In the Maimonides Brooklyn Aortic Center, we've done a very simple thing. We took the psychological problem and, stigma out of it. We have our psychiatric team see every single patient. Anybody who's in-house for any reason, no matter what, sees psychiatry. Anybody who has got aortic disease gets told that they need to be seen by a psychiatrist. They get evaluated for anxiety. And the people that have these very dramatic events, they must be seen by psychiatry and be told that there is a significant event of stress and anxiety that's going to play into their lives. Now, the people that are sitting in the watch and wait group, they're no different. Their situation is, oh, I have this horrible thing, la, 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 my head's going to blow off when I'm having dinner and stuff like that. And I have to tell you, I've had a very rare patient say to me that they want to have it done before the recommendations. And when I've thought about this very clearly, I have to say it's a very simple thing. I walk into patients' rooms, I sit there and I speak to them very casually, and I do not jump up and down and say, you have to have this out right now, you're going to die, la, 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 la. Now, there's a moral hazard, if you will, in certain scenarios where if somebody may benefit from operating more than others, there may be a different approach. And I am certainly not throwing stones at anybody. All I'm saying is that for me, it is extremely important that I let the patient understand that these are the rules that we live by, that govern our decision making. And how do I check if these rules are correct? Well, unfortunately, and this is the painful part, and I have to say this because here we are in this space. If I follow thousands of patients in my aortic center every year, and I see them year after year after year, and I don't say anything, I will wind up with one patient who dies, who does not meet criteria for surgery the last time I saw them, about every 2 years. So what's the statistical evaluation of that? It is way, way less than 1%. It is way less than 0.1%. It is way less than anything that I can fix with following statistics differently. Why am I saying that? Because if I change the time or size criteria for me to do the surgery with a risk of death from surgery, which is the best it's ever been at about 2 to 3%, that is way more people than I just described to you. Yeah. And so I sit there and I explain these statistics to my patients and I lay it out to them and I say, listen, if you really want me to do the surgery earlier, I will do it and I'll do my very best. And I believe very strongly that your personal statistical outcome is going to be better than what I just told you. But guess what statistics are for one person? 0 or 100. Are you going to be alive at the end of the surgery? Yes or no. Are you going to have a stroke? Yes or no. It's binary. If I take 1,000 patients, well, that's a different conversation. But for any one individual person, the answer is either yes or no. And so when you have these conversations very, very, very clearly with people, it makes them go, well, yeah, no thanks. Let's move along. If you choose to change that conversation slightly, I could probably convince every single person that walks into my office, including people that don't even have an aneurysm, that they should have surgery. I hope that all of them would tell me to go fly a kite and not subject them to this risk. So that's the anxiety. Number 2, you talked about the growth, and then we'll go on to genetics because that's too complex. So if I took a CAT scan of my own personal body, I do still fit in a CAT scanner, just barely. But if I go into the CAT scanner of my aorta as read by the same person, if I did it 5 days this week, would be potentially 0.5 to 1 millimeter off on the edge. And there's 2 edges, so it could be 1 to 2 millimeters difference in size. So let me tell you what that means. If I tell you your aorta is 4.5, you could come back the next time and I could say 4.7, but it's no different. If you come back the next time and it's 4.4, you're going to bash me over the head with, whatever you're holding. The point is that you have to understand the variation, and the variation changes with hydration status. It changes with your blood pressure, and it certainly changes with the quality or the fidelity of the CT scanning images. And as CT scanners get better, and as we do more and more cardiac gated CT scans, we are going to get better numbers. And here's a crazy thing. I had to check that there's no radiologists in my office. If you give IV contrast to someone who's got an aortic aneurysm, almost every radiologist will read the aorta smaller than if you don't give IV contrast. Isn't that crazy, Karen?
That is crazy. That's the first time I've ever heard that.
Well, I was withholding that from you last time we talked to save it for this so that your surprise and excitement could
And
be
so
picked up
always learn
on the
something.
video. That's the fun part. That's what was there for you.
Right. Why is that?
Well, it's because on the CAT scan imaging platform, when the contrast is so bright, the wall, which is somewhere between 1 or 2 millimeters thick, is not well visualized. And the radiologist, who, if they're not really, really seasoned, and even ones that are, they measure the aortic wall as a smaller structure. Now, how do we fix that? I get a lot of CAT scans without the contrast, which all the patients really like, but I get cardiac gating so that the size, and when I do cardiac gating and I get the CAT scans done without the contrast, me and the radiologist are more likely to have a more uniform measurement. But remember, if you have an aortic dissection, you're always going to get contrast because we got to know what's going on with the flow. Very important. All right, so the last thing you talked about, genetics. Genetic advances have been unbelievable since the human genome was sequenced in 1999, 24 years ago, when I graduated from medical school. Goodness gracious. So the reality of the issue with genetics is that we have so much that we know and so much that we don't know. Cancer is, we're getting a hold of a lot of stuff, but not everything. And aortic disease, same. We have some genes that are clearly known and other genes don't know. Still, Karen, still, if you take the population, as common as it is, as we've talked about, and you analyze everybody's genes, still 80 to 85% of them will come back with no hits on the current 34 different genes that are associated with aortic aneurysmal disease and aortic dissection disease. And on a little caveat, if everybody wants to run out and get their little thing, make sure you've got your life insurance and your health insurance and your disability insurance all solidified, because if one of those companies gets a hold of the information, if you happen to get a hit for one of those abnormal genes, it's going to cause you a little challenge. So before you go and do this, find out from your surgeon, if you have an aneurysm, is the surgeon going to do anything different with the information obtained? Here's one surgeon to tell you that it is an exquisitely rare patient who will get a result that isn't already well appreciated clinically, that will change how often we get the CAT scans, that will change the surgery that will be offered, that will change when the surgery will be offered or the type of surgery will be offered. The genetics of aortic disease is in a relatively evolving state, not quite primordial anymore, but it's definitely still evolving. And it's not exactly ready for prime time clinically.
No, and you told me that a while ago, which was now having an adult son, of almost 25. We've had frank discussions, and, his cardiologist said, we're just going to treat him like he has something. We're just going to assume that there's something there, even though there hasn't been anything of significance in myself. We're just going to assume, and we're going to scan him as if he did have something. So he looked at me and he goes, well, then why do I need to be tested? I don't want to know if I have anything. I'm just going to keep doing everything that I'm told to do. Nothing's going to change one way or another. And I've always appreciated that information. I didn't really think about it, when this first happened to me. I was like, run out, let's go figure out what's wrong with me so I can save the family. And then the reality is the family gets saved by going and continuing to be monitored. That's what they need to do.
Absolutely. And that is the real message. The real take-home message is that whatever the family is carrying through the generations needs to be investigated as the generations go through. And the more you deny that, the more you deny your opportunity to live a longer and healthier life. That's just the way it is. We're all carrying it. There's nothing, we can't escape that.
Exactly. And before I check to see if we have any questions, the last thing I want to talk about that tends to go around in the community a lot, are questions about exercise and restrictions. And it's always so interesting to hear what different people say their own physician tells them. Some are, I'm only allowed to carry no more than the weight of a milk jug, or somebody else says, oh, 30 pounds. And I've always loved what you've had to say. And the same thing goes with exercise. There's just no standard. There's no, we want your heart rate here, your blood pressure here, and what that means. And I've kind of personally, I don't think it's wrong. I could be, you'll tell me, just adopted this. As long as I'm walking, it's what a human has to do, then I think I'm okay. I'm not really lifting anything more than what I would put in my suitcase, because when no one's looking, I got to drag it out of the trunk anyway. It's not like I'm carrying it around on my head and just walking around and doing this with it, right? So if I can lift that up and exhale when I put it on the scale at Southwest, then I'm okay. It's like 42 pounds, but it's a one-time lift. It's not that big a deal. So explain to everybody the way that you talk about sex, exercise, lifting weights, restrictions, because it's so interesting what you say. I find it entertaining and interesting.
We've all gotten together basically, and we've said, well, how do we figure out how to explain it to any one individual? We used to say, you have to lift half, you can only lift half your body weight. But as we know, anybody who's traveled in this country, especially, half the body weight is very impressive for some people. And so that doesn't really work. But then on the other side, you say, wait a minute, half the body weight's kind of unreasonable for some people who can actually lift a lot more than that. So what could we actually come up with? And the answer we all kind of stuck with was 100 pounds. 100 pounds, if you think about it, there's a lot of different areas. You can think about it. If you go into an airline, I think it's 75 pounds is the heaviest bag you can have. So 100 pounds is like way above that. Mm-hmm. An air conditioner, if you try to carry an air conditioner, it's not even 100 pounds. Half of a couch isn't really even 100 pounds. If you start to think about the things that are 100 pounds, and then you start to think of yourself, like when would you ever really pick up anything heavier than 100 pounds? It's very unlikely. But on the other side, I had a guy in my office today who was bench pressing 420 pounds when he was a younger man who's got an aneurysm. And he said, I listen to you, doc, I don't do that stuff anymore. But the man is enormous. He's about 6'6", and he's about 280 pounds. And there's no question in my mind that him pressing 100 pounds is kind of a joke. Yeah. But that's not the point. The point is that we have to just say what and why. And so we've stuck with 100 pounds. Mm-hmm. The gallon of milk thing is for immediately after surgery to protect you from sternotomy breakdown. Mm-hmm. But after that, it's we all kind of agree to 100 pounds. But most of us, you have to work up to do 100 pounds. The little old ladies laugh at me, and the young, strong men laugh at me. And I figured if everybody's laughing at me, I probably hit it right on the money.
Good.
So the other thing I talk about is the other issues, right? Because we want you to have physical activity. We want you to get out. We want you to run. We want you to jump. We want you to do stuff. But contact sports don't work. So as we say, no contact sports anywhere except in the bedroom. Contact sports in the bedroom, absolutely required for a natural, healthy life, and you should definitely participate in them and not give it a second thought. The reality of it is that getting your heart rate up and participating in physical activity and having sex, these are very, very important things for a natural and healthy life, and you shouldn't give it a second thought at all. The objective, if anybody wants to allow me to go from sex to calculus just briefly, is if you remember calculus, the issue of change in pressure over a change in time is what we're talking about. And the change in pressure over time, again, we're not talking about sex right now, we're talking about calculus. The change in pressure over change in time is the area under the curve. The area under the curve is what you're going for. And if you exercise for an hour a day out of 24 hours, the area under the curve is going to be nominally changed for aneurysmal disease. Your blood pressure is going to be nominally changed if you take your medicine. Mm-hmm. And if you don't have sex, you're going to be miserable, whether it's with yourself or other people. The point is like you have to do things that fulfill your life, and you have to do things that keep you healthy. So be intelligent about what you do. And if you're sitting there underneath a bench press and pushing up 300 pounds, you're taking, you're blowing out like blood vessels in your eyeball. This is clearly not a healthy thing to do for anybody, let alone for somebody who's got an aneurysmal disease.
Exactly. Oh, gosh, you're so entertaining. Okay. Oh, Joshua, What kind of comments or questions do we have at this 4:45 p.m. hour?
Let me make sure that I can be heard. All right. Let's say hi to a bunch of people first, and we do have a couple
Sure.
of anonymous questions that have floated into the form.
Sure.
So hi Molly, hi Christina, hi Terry, hi Tim, and they're the only ones that are chatting so far.
Okay.
One of the first questions that floated in was, Tim asks, can a growth hormone deficiency result in an abnormal valve not forming properly?
I want to thank you, Tim, for a question that I probably have absolutely no chance of answering, but I can wax poetic for the next 20 seconds and tell you I have no idea. And we'll just leave it at that. That's a curveball. Thank you.
Okay. I like it. Molly says, is it responsible of a cardiologist to not order a CT with contrast when there is a known 4.6 plus ascending aortic aneurysm?
So here's the thing. I can only assume that it was identified with echocardiography. Echocardiography is problematic in that you can't guarantee the actual size that you see on the screen because of the nature of the way the echo waves go in and out of the patient. So it is not a matter of responsible or irresponsible. It's a matter of, if you want a completely accurate assessment of the aorta, the aortic root, the sinuses, the distance across the sinuses, where the aneurysm stops and whether the arch is involved and whether the arch vessels are normal and all these kinds of things, you should definitely get a CT scan, at least a baseline CT scan. If you want, you can get an MRI. I'm not saying you can't, but the contrast is absolutely not necessary, but they should do what's called EKG or ECG gating. And that's when you have the ECG electrodes, the echocardiogram, the EKG electrodes on you, such that the software will pull the images in time with your EKG, and it makes a much clearer picture. The value of that is incredible to somebody like me who has to sit and measure this stuff over and over again, because I can be off by as much as 2, 3, 4 millimeters because the movement in the aortic root can really make it very inaccurate when I try to measure stuff.
Let me ask a quick question. So a patient like myself who's had a dissection but is horribly allergic, even with pre-medication, to the contrast, would you still prefer CT without contrast, pre-medicate, or just go with the MRI? The MRI.
So the problem is that it depends, as always. If someone has a stable, relatively stable dissection, and you're really going to be making decisions because it's been a number of years, you're going to be making decisions because of absolute size. You could, and I do sometimes, especially with type B dissections and residual type B dissections, which is usually the only ones that I follow, because type A's I go to the surgery, right? I will actually sometimes get a gated non-contrast CT scan, especially if I'm looking for arch enlargement, and that's it, because the arch I can see extremely well. If I'm looking for aortic root enlargement, sometimes that's not as easy to see, especially in a postoperative patient. So there are the challenges. I don't always need contrast, and it's usually not allergies. It's usually people who have kidney problems. I have to manage people who've got bad kidneys and say, I'm not willing to put you on dialysis to get information so I can say, have a nice year on dialysis. That makes no sense to me. So all of these excessive, unnecessary tests need to be balanced against the patient's comorbidities and other medical problems.
Thanks.
I like it. Okay, so let's see here. You blew Christina's mind with the fixed my dad's own valve with success. Terry says, thank you for explaining the valve and the door sizes. It helps to put it in perspective. And Molly says, I was told my ascending aortic aneurysm was not related whatsoever with my dad's very large abdomen aneurysm.
So this is a matter of communication, and one of the things that those of us who've been involved with Think Aorta and with all of these type of events is really changing the falsehoods of information that was perpetrated by all of our medical schools. I will tell you the information that I got in medical school in the 90s is not the information I'm giving you now. And it is really the responsibility of all of the practitioners to become either up to date or defer to the experts. You have two choices. The one thing you can't do is not become up to date and not defer to the experts. And that's where the situation that you describe is someone who has got information probably from maybe even the 70s or 80s. They're carrying that information because they believe that aortic aneurysmal disease is sporadic. The chances of it being sporadic is about the same chances of the overwhelming majority of cancers being sporadic. We now know, because we have identified all these genes, that people who get cancers have genes that cannot fix problems in the genetic code, resulting in abnormal genes that result in cancers. It is not a random event. Now, if you get exposed to some horrible cancer-causing agent, yes, you're going to get a problem. But the people who have the genes that don't correct those problems, they get it way worse. And some people, you may have seen them, classic 90-something-year-old person who's been smoking their whole life and says they won because they don't get cancer and they think it's not true. Well, it's not true for that one person. But remember, we talked about the 0 and 100. We don't live in those worlds. We're physicians. We need to live in a world where what do the majority of the people do when the majority of the people get exposed to a thing? Well, the majority of the people get this thing. Of course, there's outliers. Of course, there's people that buck the system. But the truth is that the 90-year-old person who's been smoking since they're 10 years old and has never had cancer, they probably have extremely effective genes that fix DNA, irregularities and damage. Not because they don't have a cancer gene, they have maybe robust other things. I mean, these are clearly people that should be studied. These are clearly amazing people. Take like somebody who's in the NFL for 35 years. That is not a person with a connective tissue disease. That's not even possible. You understand? These are the things that we start to have to put our fingers on a little bit more intelligently, as opposed to running around thinking we actually know what we're talking about in the medical community. So I don't mean to throw stones at your physician, and I don't think that anybody's a terrible person, but I will tell you that that is not the best approach to the situation.
So we know that typically, from what I understand, men can get abdominal aortic aneurysms over a certain age, smoking, overweight, all these different elements to it. If somebody's father develops an aortic aneurysm, is there a cause for yourself to just get checked out to make sure you don't have something brewing someplace else? Or would you say, well, maybe I get checked out because I've had high blood pressure and my father had an abdominal aneurysm? I think that people tend to minimize the abdominal aortic aneurysms and not think that they should themselves be scanned. So I don't know what that rule of thumb would be.
The rule of thumb is the aorta is one organ. It's a continuum from the heart into the belly. And if you have an abnormal disease, you should get checked out. I already said that there's a 30 to 35% crossover from chest to belly and belly to chest, and about a 10 to 15% crossover into the brain. What you should do is realize that if you take the population and find out what the incidence of abdominal aortic aneurysms, thoracic aneurysms, cerebral aneurysms, it's minuscule compared to the population. So if somebody gets one, there's got to be another reason.
True. Okay. Go ahead, Josh.
Okay, back to me. Yay. So Molly had a comment there. Dr. Youdelman, I was that patient. Stanford surgeon said to come back in 6 months, and I booked the surgery anyway to happen in 2 months. I dissected 1 month later. And then you were giving another example, and she says, I was that patient. Also, surgeon ordered genetic testing to rule out aortitis, which he said could alter my valve sparing surgery.
And
so she's our queen of self-advocacy.
well, first of all, I'm very glad that you're here to ask the question, because clearly you were saved, which is phenomenal. But you know, the patients that dissect on the list, as we call them, or die on the list, it's brutal. It's brutal for every single person involved, because we all go back and we look at the aortas and we try to examine. So I've been in this business now 20 years, and I can tell you that on average, I have not even had one every 5 years. I've only had about, that I know of, right? So there's always people that I don't know of. But I've certainly had less than 10 that I know of. But it's brutal. It's brutal, because you have them teed up, and you don't want to subject anybody, because on the other side, and this is the really hard part, is I have had very, very, very high risk people come and say they want to have surgery, and they want to have surgery, they want to have surgery, and then they can have a stroke, or they can have bleeding problems, they can have prolonged hospitalizations and other issues. And then that's really tough too. So the problem is this is never a zero-sum game. Never.
Okay, I like to hear that too. Hello, Lalitha. Her question is, how about physical therapy for upper back and shoulder pain?
I think that your partner should give you massages whenever possible. So
I agree.
That's definitely number one. And you start with that. But, you know, physical therapy should never ever be more complicated than any physical exercise that you do, you know, like at home. Most physical therapy is very focused, very pointed. You know, it's designed to exercise muscles at a very low weight, low resistance, high rep rate. And so I can't even think of one physician-sponsored physical therapist advocated thing in physical therapy that could cause a problem any more than the stuff that you would choose to do at home or at the gym. Now, of course, it could cause a problem, but you know, we don't like to talk like that. We have to balance our fear with our health. There's no question that sitting in your, you know, living room watching TV for the rest of your life is miserable. It does sound lovely though, for maybe just for a few days. But I mean, it's miserable if the reason that you're there is because you're afraid to do stuff. You know, you have to take care of yourself in every way that, you know, you hear about on TV. Eat well, exercise, you know, socialize.
So if you have residual shoulder, back, or upper chest pain from having had surgery, and you're saying it is okay if you want to seek out the help of a PT. I know some people ask about a chiropractor. Is that a yay or a nay? Because massage therapy is a yay, PT is a yay. What else can you do to help resolve the aches and pains after open heart surgery?
I think the majority of the physical, you know, problems that occur are all basically all nerve related, right? So after about a year where the nerves and the muscles and the bones and the tendons and the cartilage are all as healed as they're going to be, really you're left with residual nerve pain. And that's why Neurontin and Lyrica and antidepressants that work way more complicated than just, you know, making you like smile. I mean, that's not what they do. They're way, way better at solving a lot of these problems. You know, once you break it down in a very, very simple way, there's no way that you're having bone problems, muscle problems, you know, 5, 7, 10 years after surgery. These are all nerve-related issues that are either being re-injured or stimulated by chronic inflammation, or sometimes when there's been bone breaks or things like that, you've got nerve endings that are sort of zipping against bones and all kinds of stuff. The truth is that if you've tried all of the usual stuff, so steady regimen of physical therapy and activity and getting out there and la 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 la, and you're taking, anti-inflammatories as best you can, then it's time to start thinking about, Lyrica, antidepressants, and like a gabapentin, Neurontin. I mean, the idea is that you have to address what is the most likely cause. It is not likely that the position of the bones in your body has anything to do with the reason you're having chronic pain after heart surgery. It's going to be scar tissue pulling on your spinal nerves. I promise you that. So, I'm going to apologize in advance for all of my patients who are out there with back pain, but everybody has discomfort. And as you get older, discomforts get more complicated. The problem is that if you've had an aortic dissection or you've had, an emergency surgery, everything is a beeline for that problem, and then you're scared. I totally understand that. As I'm going on in my career, I understand it so clearly. The problem is I can only reassure you and tell you that stubbing your toe when you're not wearing shoes in the summertime has nothing to do with the fact that you had an aortic dissection 10 years ago, despite the fact that when you wake up in the morning, your toe's going to hurt and you're pretty sure it's going to be because you threw an embolism to your toe. But we both know that that's not a reasonable thing to approach. And you're laughing because you've had those moments.
I have definitely had moments similar to that. Yes,
and
I have.
You have to stop, take a deep breath, and turn to your partner.
I do a body scan.
Yeah,
and I learned that part of grounding. I do an assessment, I reset myself, and I really focus on what is my problem. Is it new? Is it the same? Is it stuff that I felt before? And by the time I'm done all that, 15 minutes have passed and the feeling's gone away. And I'm like, oh, okay. And then that's it.
Telling your partners, and the people that are around you that these things happen is a way of including everybody and helping you. Because if you exclude everybody because they haven't had an aortic dissection, first of all, you don't want to include them in your group. But if you include them on this part, really helps you to cope with some of this crazy stuff that happens inside your brain.
Absolutely.
Okay, I'm going to transition over to some of these anonymous questions. They're starting to look like we're getting some.
Sure.
I, 54 male, was just recently diagnosed with an ascending aortic aneurysm, 4.5 centimeters. Also have bicuspid valve and aortic insufficiency. My CT surgeon says we're in a wait and see for my surgery. My question, for years before the diagnosis, I noticed that my BP was always higher by about 10 points in my left arm. Was this just a coincidence?
10 points is not enough to make a fuss. We say 20. That is arbitrary. I'm not saying it's not arbitrary because obviously if your blood pressure is 200, 20 points is 10%. And if it's 100, 20 points is, no, I didn't say that right. The other way, 20 points is 10% versus 20 points is 20%, something like that. Anyway, listen, I'll do calculus, but basic math, not so good. The idea is that that difference in blood pressure is probably not what we call pathologic. It's not pathologic of a coarctation. And I assume, having had a CT scan, that somebody would have identified you as having an actual coarctation beforehand. Now, in terms of your aortic size, it sounds like if you have aortic insufficiency, that you're probably going to wind up going to surgery based on your symptomatology from your aortic valve insufficiency, or if your ejection fraction, so the amount of blood squeezed is good.
Mm-hmm.
Squeezing? Squeezing? That's not right.
Squeezed. Sounds good. Squeezed. The amount of blood squeezed. Pumped, pushed, pick a word.
Pumped is better. The amount of blood pumped out of your heart is supposed to be between 55 and 75%, not 100 and not less than 55. So if your ejection fraction is 50 or 45, you probably should have the valve done, and then they could do the aneurysm at the same time. So definitely something to figure out. Depending on where you're at with the aneurysm, and if you have no other significant family history issues, there's no reason to do it until 5 centimeters right now. That's where we're all at, it's 5 centimeters. But if you're sitting there at 4.5 centimeters and the valve starts to become leaky, or your ejection fraction starts to decrease, or you start having symptoms when you're doing any physical activity, then you should have the surgery done, because straining your body just to wait another year or two, it doesn't make any sense. We know that that's not the right thing to do.
Okay, thank you. Next question is, I have an aortic aneurysm, no surgery yet. Kids are in their 20s. Should they be screened now?
Well, it depends on how old you are. If your kids are in your 20s, you need to be at least 35, 40 years old. So the kids should be evaluated 10 years younger than whatever age you were when you were identified. So it could be pretty close, 25, 30, sort of depends on the age difference. And again, we talked about it. If you have very high risk family, multiple people, multiple surgeries, and aortic dissections, it's a very different scenario than if you don't. Because if you don't, that's a different substrate. And it's really important that you understand that. I suspect that over the next, 50 years, there's going to be far more nuanced approaches to patients who have aortic aneurysmal disease versus dissection disease. And we may be operating on people who have dissections much earlier. The one thing that I definitely know is that if we try to get everybody to have surgery before they have a problem, we'll actually hurt more people than what we're doing now. So, you have to approach everything with a certain degree of balance.
Okay, just a few more anonymous questions and then some comments, and I think that'll wrap up the chat. We were talking about upper back and shoulder pain. So what about stretches, electric stimulation, and heat and ice?
All of them are good. The TENS unit, which I assume is what you're talking to, TENS, trans epidermal neural stimulation units are wonderful. They are usually best used in association with chronic bursitis and things like that. They may not really help except for like 20 or 30 minutes, but they often help more if you have associated physical activity, associated with them. Like I know they work really well for shoulders and hips and wrists and elbows and knees and stuff like that. But they're all good. There's no badness about stretching. Remember, your heart and your aorta are beating and stretching in a normal case. I mean, your aorta actually beats like this every single time your heart beats, and it's supposed to. It's supposed to be stretchy and flexible. Don't get scared. I do that to people, and they're like, oh, I don't even want to talk about it. I was like, you don't want a rigid pipe of an aorta. That's bad, super bad. You want it to be able to absorb this stuff. So all those things sound good, healthy.
Okay. Hello, Dr. Ben. Thank you for such great information. Thank you for explaining gated CT scan. I worry about getting so many CT scans with contrast, so I appreciate your information. Tammy.
Yeah. What's the name?
Tammy.
Oh, hey, Tammy. I think that one of the things that we often don't appreciate is that the advances in technology that we have allowed significant changes in the way we do things. And going back to that other comment about like probably the older doctor who said, oh, everything's fine. I have to fight with the radiology department in my own institution where I have my aortic center to do some of these studies, because even they don't appreciate, because when they go to radiology school and radiology tech school, they don't get told the value of the advances in technology such that we don't need to give people IV contrast. And those are the kind of things that drive me a little bit crazy. I'm like, I appreciate that I'm teaching people things, but should I really be the person to teach these people when they should be saying, oh, look what we can do now that we've got this incredible software package to be able to see the aorta. Maybe we don't need to give contrast. Maybe they should do a study. It's like kind of crazy stuff.
That's fair. Let's see here. I have a 4.3 ascending aortic aneurysm. Right now, I only see a cardiologist. Should I see a thoracic surgeon just to develop a relationship?
Well, that answer is always going to be yes. And the reason that answer is always going to be yes is that 80% of the time, that cardiologist is not reading that CAT scan. and I'm being generous. I actually don't know any cardiologists that actually know how to read CAT scans. So that you're actually shorting yourself because you're relying on a person that's never held an aorta in their hands to make a decision about a life-saving treatment for you. So the simple answer is you need to be followed by a aortic surgeon, not just a thoracic surgeon, but a aortic surgeon. Now, why am I so specific? Well, because what I do for a living is different than what my partners do for a living. My partners specialize in transcatheter valve, mitral valve repair, mechanical circulatory support. We all have our subspecialties. We all can do the things that we can do, but being subspecialized in a way, I promise you, when I get done measuring an aorta, most of the measurements are totally different than the radiologists. And I've explained it to the patients where they understand that I'm not reading it the way they are. Mm-hmm. So now you're talking about following with a cardiologist. I wouldn't do it. Find somebody. And if you need any recommendations in the city that you're in, we can create an opportunity offline for you to get you the help that you need.
Well, one of my favorite sayings that you say is, I'm available. All right, so that looks like the conclusion of our anonymous questions. I want to say hi to Lauren Willie. She says, hi, Dr. Youdelman.
Hey, Lauren.
She's got a comment here lower, too. So when you were prescribing massages for your partners, John Burney said, can I get a prescription for that? And so I would love if you sent us a prescription pad with just hugs and massages signed by Dr. Youdelman.
Love that.
We would sell those like hotcakes.
There'll be prizes for sure.
Can do. The first one I think I wrote to my mom many years ago when I got my prescription pad. I recall doing that.
Very nice.
Awesome. All right. So Tammy says, Dr. Ben, you've taught me so much about self-advocacy. Information is powerful. I find doctor interact with me differently when they realize that I have a little bit of understanding of the aorta.
Yeah. No, it's really, really important that you explain to people that you understand and that you have very pointed questions, and that will change their approach to you. And this is my dad's rules. My dad's rules are very simple. Find doctors that you like, do what they say. When you leave their office, don't think about it again. Mm-hmm. If you go to the doctor and you don't like them, find another doctor. Don't sit there and fight with anybody. Just walk away. If you find someone that you trust and that you like, just do what they say. It will give you a certain degree of peace between doctor visits. I can't take away the stress of the CAT scan anxiety, the scan anxiety, the follow-up anxiety. But I think we all know, because we're all patients and we're all involved, if you believe what your physicians are telling you and you don't leave with that lingering question that they're telling you the wrong information, if you believe them, it's so much easier to live your life in between visits.
I mean, when you're going to have a child, we're all taught that we should interview pediatricians. And nobody thinks that we should be interviewing physicians as adults. And after my dissection, I changed cardiologist, I've changed GI, I've changed primary care, and it felt weird to just sit and have a conversation. My first appointment was consultation. I needed to explain my communication style, find out theirs, make sure it's a mesh, make sure they're comfortable taking me on as a patient. And not everybody was. And so I live my life exactly the way you just described it. I want to know I have a good relationship and I'm trusting my physicians. Otherwise, I'm going to be a mess, and that's not going to help the situation.
That's excellent advice. One last thing, says Tammy. Please continue to educate thoracic surgeons about the mental health piece of this disease. You are the only one that I know that acknowledges and studies the mental health issues. And I can applaud that because we do your surveys every year. Molly says, what are your thoughts on occasional deep tissue massage? I'm 3 years post-op with a residual B.
Are you hitting on me?
What are your thoughts on occasional. I feel like she's trying to book a flight to New York is what I
I think
feel like
she
is
wants
happening.
she wants a prescription sent to her. Just send
I
it. We'll
hope
make sure she gets
hope
it.
my wife isn't watching this. I could be in real trouble.
I mean, isn't it
No,
true that your aorta is so in your body cavity that having your muscles rubbed, I can't
listen,
imagine that's
your
going to be a problem.
muscles are not related to your aorta.
Right.
You
Right.
need to there, there's such an important thing. There's a calm the down. Like we need to approach this. Like I understand as much as someone who's never had this condition, I understand that this sucks. You're like overwhelmed with stuff. But common things being common, you're not going to hurt, your right arm by massaging your left foot. You have to approach things with just try to bring it down. Try to bring it all the way down. Things that are going to raise your blood pressure for extended periods of time, spiking them through the roof, out of control, skydiving, which I think many people have done actually, like trying to lift crazy weights, like sitting there under like a foot bench press with thousands of pounds, like, I mean, these are things that don't make sense. Lying there at a table with some peaceful music and some like lavender smell and getting massage, that's like fantastic. That's great. That's so great. Like enjoy it, and don't let this disease ruin these things that you used to enjoy. Or I'm going to kill you. No, I'm kidding. No. Come on, enjoy your life. Enjoy your life. Enjoy your life. You have to enjoy your life as best you can. Don't let this be who you are. This is just part of you. Don't let it take a hold of you. I yell at patients every day. I'm like, stop it. Cut it out.
Mm-hmm.
Really, I mean, and you have to tell your partners in your life, don't, help me carry the load, but don't sit there and enable my craziness. Like you have to, you have to have people on your side to like help you through this stuff.
I got
100%.
you. Lavender scented lotion, 100%.
Yes. I hear that's good.
Let's see. We said hi to John Brennan. He showed up. Molly says, I'm so grateful for you, Dr. Youdelman. Your time is precious, to give us this hour and beyond is generous. Thank you. Rob says, hey,
pleasure.
listening from the car. I said, hey, chef.
Who? Oh, the chef.
Chef
Hey, what's
Rob.
up, chef?
It's our aortic chef.
And
Yes.
Lauren was saying, it's true. I'm a patient of Youdelman's, and we had to fight with the insurance company to get my surgery approved. I was in the watch and wait realm, but have a family history.
And that's so annoying. It's so annoying.
Velda says,
Yeah,
thank
but
you for this.
we go to bed. Go ahead, Josh.
Oh, Velda says, thank you for this. And Rob says, travel the world, which is something that he did.
No, and listen, that there's something about this. People want to be like, standing next to their, hospital where they're going to have the surgery, God forbid their head blows off. Don't do that.
Mm-hmm.
If you want to take great care of yourself and you want to be a little bit more careful, then take your medicine every day and maybe don't bench press 150 pounds. Like, you know what I'm saying? Like, there's different ways where you can be particularly careful, but not enjoying your life is not the way to do it.
No, I can remember calling you. I was in Disney. I texted you and I said, can I go on the Tower of Terror? And you were like, yeah, I mean, but there's a whole thing to, it's not, there's no G-force involved, but it's, are we talking about continual spikes for the entire ride? And so, next time I went, I gave it some thought. I would look at these coasters. I would ask questions. They probably thought I was insane, but things that had a 0 to 60, super fast takeoff where my I'm not doing that to myself anymore, but I did enjoy a roller coaster for like little children. And it was so awesome. And I have fun on the other rides that are simulators and they're great. So I enjoy my life. It just looks different, but who's to say that if I didn't have the dissection at 54, I would not have made the decision to stop those heavy G-force coasters anyway, because as I was getting older, I would have stopped. So I don't think that I miss out on things at all. I make accommodations, and I kind of look at it as if there's things that I can't do, but there's a lot of things I can, and I just live life differently. It's just different, and different isn't bad.
And it's going to happen anyway. This is the part. I was having a conversation with a guy today, and he was saying, "Oh, I don't want to this, I don't want to that." I was like, "Listen, I don't really care. But let's just take your aorta out of this conversation.
Right.
You're not allowed." Okay, so this is a 68-year-old guy who literally is telling me that after I told him he could lift only 100 pounds, the guy's very, very big and strong. And he's like, "Well, you know how it is. You go to the gym and you don't want to appear like an idiot." And I was like, "I get it." So he said, "You know what I did? I started using the machines because they can't tell how much I'm lifting, and then I'm not embarrassed." And I was like, "There you go.
Make an
That is
accommodation.
Like a perfect accommodation.
Right.
No one will know. You used to push the whole machine worth of plates. Now you just push 5 plates. Who cares? I got news for you. Nobody cares.
No.
He's 68 years old and he's still like worrying about how cool he looks in the gym. I said, I think that I'm cool enough to do that when I'm 68 years old. But I mean, these are the kind of things. It's inside your own head, some of this stuff.
Exactly. Exactly.
What else we got, Josh?
Well, it turns out that Tammy here is Tam Tam. Keith says hi. Cheers to you.
Yeah.
Hi, Keith. Hi,
Keith.
Tammy's hubby.
Yes, Tammy's hubby. And that concludes our chat. I do have some inquiries happening inside of the anonymous request for.
Yeah, what's inside the anonymous request?
How to reach out for recommendations. So should
we
go
out
with
to recommendations? Yeah, well, they can get to you. I can certainly help you guys in any way you want. There's certainly a good way to get in touch with us, and then we can talk about that We can talk about that a little bit.
Yeah. At this point, they can send an email to info@aorticope and just note what your question is and what you're looking for, and then I will pass that information on to Dr. Youdelman.
Thank you. No problem at all. I'm going to have to take my leave, my friends. It's been an absolute pleasure.
It's been great. I was not prepared for that. You clearly had some really good, either Starbucks or Dunkin'. I don't know what's at your hospital, but
I actually had a Thai iced coffee on my way. That's where I was walking from.
Totally can tell. That's why you were like 30 seconds late, because you're like bouncing off the walls and I can't stop laughing. I started breaking into a sweat, but that's what makes this so human and so relatable to everybody, is when you get me cracking up. It's always a pleasure, my friend.
Well,
Thank you again so much.
It is a pleasure. Thank you so much. And I really appreciate it. And thank you for having me back. And Josh, as always, you're my hero. Love the new hairstyle, baby. Looking good.
I did. I left my camera on the whole time. Whoops.
You did.
Things I forget.
All right. Well, we appreciate you. And before we go, everybody, don't forget to click like, click subscribe, click that bell so you're notified when we decide to do this again with Dr. Youdelman or whomever else. And don't forget to share it, because somebody will get something out of this conversation. I get something out of it every single time. And until then, thank you again, Ben, my friend, Dr. Youdelman, and we'll see you again soon. Take care, everybody.